Good evening and a warm welcome to all the dignitaries present here. I'm Satyashiva from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the Indian Society of Pediatric Neurosurgery, and the focus of today's session is Pediatric Neuro-Oncology Spine. So let's begin today's session, for which I would like to invite Dr. Shuhas sir to take over. Over to you, sir.
Thank you, Shresi. Good evening, everybody. Thanks for joining this session of IndusPM Virtual Classroom for residents and trainees. As a part of our IndusPM endeavor, we have been conducting virtual classrooms for which are meant for residents and with the perspective of pediatric neurosurgery for them through our faculty in the national and the international level. And today we have as a part of our neuro-oncology sessions, today we have picked up spine, and the spine sessions will be in two sessions. And today's session is on the basics of pediatric intradural spinal anatomy, epidemiology, and diagnosis, and the extramedullary tumors. So today we will conduct these topics, and let me tell you that this will be available in the YouTube later. So in case you have missed it, in case you are not completed, you can always go back to the YouTube and have a look at this class and the other classes which are held at the last Sunday of each month. Sachin will, Dr. Sachin from AIIMS, additional a professor from AIIMS, will conduct the rest of the session. Thank you, Dr. Sachin.
Yeah. Good evening, everyone. I think this is very important activity which is useful to residents. And today we'll be having a discussion on pediatric neuro-oncology and the spinal tumors, what you are supposed to know as a resident, and to clarify some of your doubts regarding this topic. And to have this discussion, we have two teachers, my colleagues, Dr. Ravi Sharma, who was a faculty at All India Institute of Medical Sciences, and currently he is working as a senior consultant neurosurgery at Paras Hospital, Gurgaon. He will be discussing about the anatomical consideration, epidemiology, and diagnosis of these spinal intradural tumors, especially pediatric age group. And the second speaker or the teacher for this session is Dr. Satyashiva Munjal. He is the Associate Professor of Neurosurgery at the RML Hospital, Department of Neurosurgery, New Delhi. And thank you so much for joining. And I hope that you will benefit from both these topics. And if you have any doubt, you can just put your questions in the chat box, and we'd like to take it during the course of discussion today. And feel free to ask any question which you feel there is some doubt or need more clarification. We'll be happy to answer. Thank you so much. Dr. Ravi, I welcome you on behalf of Indian Society of Pediatric Neurosurgery. You can start your lecture.
Okay. Thank you so much, sir. Good evening, everyone. Thank you for this opportunity. So really grateful to Dr. Suhas and Dr. Sachin. So I'll start my talk. So my talk is on pediatric intradural spinal tumors, anatomical considerations, epidemiology, and diagnosis. So first of all, we need to understand the various compartments which exist for a spinal tumor to grow. So this is very, very important for residents to understand that if we say spinal tumors, so that is a very, very broad term. So that broad term might include a lesion which might exist here in the extradural space or the epidural space. So it might cause the compression of the spinal cord from the outside, which is an extradural mass lesion, or that lesion might be arising or might be entering into the dura as an intradural mass and then compressing the spinal cord, or that mass might originate within the substance of the spinal cord and then it's called an intramedullary lesion. So an extradural lesion generally causes what is effacement of the epidural fat. It causes the inward displacement of the dura and compression of the spinal cord from the outside. Whereas a lesion which is having an intradural region. Here the epidural fat is preserved. There is no inward displacement of the dura, rather dura is being expanded outside. And the ipsilateral, which is the same side intradural space, shows a widening cleft sign because of the separation of the lesion from the spinal cord. And you can see a CSF sliver around it, or CSF cleft which separates it from the spinal cord. Whereas an intramedullary region, so which is arising from the substance of the cord itself, that causes the expansion of the cord itself. It doesn't cause displacement, it causes the expansion of the cord. So for as far as the spinal tumors are concerned, so the extradural as well as the intradural, these both compartments become extramedullary as well. So now we have three things we need to remember. So a lesion might be extradural or epidural. A lesion might be intradural but extramedullary, which is an IDEM. And the third, it can be an intramedullary lesion. So this is very, very important. Extradural, intradural, extramedullary, and intramedullary. The another thing which we students, especially in their residency while they are doing their MCH or a DNB course, need to understand the basic anatomy of a spinal cord, because this helps in clinical localization of the lesion, whether it's a pediatric patient or an adult patient. I feel this diagram, which I have taken from the net, is very crucial for understanding the relative location of various tracts in the spinal cord, as well as the orientation of the fibers from individual parts of the various limbs, like upper limb and lower limb fibers, because the location of a particular tumor, whether it's an intradural extramedullary tumor or an intramedullary tumor, these tracts can get affected sequentially sometimes and can help in localization. If the lesion is very big, at that time it might not be actually able to localize, because almost all tracts might get affected eventually. But in the genesis of the lesions, sometimes, for example, if you are looking for an intramedullary lesion, so an intramedullary lesion which is originating from the substance of the cord, where you can see the central canal, it is originating from around this central canal. So it is going out concentrically from this. So this will give you an idea that because the corticospinal tracts, the cervical and the thoracic region, are located much more medially towards the central canal, so these lesions get affected first. And that is why there's a term called as sacral sparing, which is seen in case of intramedullary lesion, because the sacral tracts are located at the periphery. The cervical, thoracic, lumbar tracts are located towards more closer to the intramedullary central canal. So that's why such lesions can present with what is called as sacral sparing. Similarly, what you need to understand is that the location of spinothalamic tracts, the tracts which carry pain and temperature, they are also located quite close to the central canal. So, and they decussate to the contralateral side, like the tracts at this level will decussate to the contralateral side and then ascend. This decussation of the spinothalamic tract makes them prone to a lesion, anything, an intramedullary lesion, which can present with what is called as a dissociated sensory loss. When we say a dissociated sensory loss, we mean to say is that there is selective involvement of the spinothalamic tract and the posterior column is spared. That happens particularly because a lesion which is going around the central canal and these tracts are crossing from one side to the other side, closer to the central canal. So a lesion here will affect these tracts, which are the spinothalamic tract, and lead to dissociated sensory loss. So this diagram, which you might have read way back in your neuroanatomy in your first year of MBBS, still holds relevant. The two things which we need to remember, one is a presentation which is similar to what is initially taught to you, like a brown sequard lesion, which was a hemisection of the cord. So an intradural extramedullary lesion might initially present with something which is similar to a hemisection of the cord. What we mean by that is we're not actually sectioning the cord, it is by a unilateral compression to start with for an intradural extramedullary lesion. So such patients might present with what is called as spastic paralysis, which is going to involve the tracts from the outside. So that is why this now, because as we have shown here, so you can imagine if a lesion is growing here from the outside, it is going to compress the sacral tracts first, then lumbar, then thoracic, then cervical. So that is why many times the intradural extramedullary lesion, they present typically with what is called as ascending paralysis. Okay, so the tracts have ascending paralysis because the sacral tracts, which are located outside, they start getting compressed, and then finally eventually we move on to the cervical tract. Whereas a lesion which might be growing from inside, it might affect the first cervical, then thoracic, then lumbar, and then sacral, leading to what is called as a descending type of paralysis. So this is very, very important, which is asked commonly in your clinical cases for your final exam. And this presentation, where a unilateral section of the hemichord is getting affected, leads to what is a spastic paralysis on the same side and loss of temperature and pain sensation on the contralateral side, because here you can see the tract fibers of the spinothalamic tracts, they cross here. So because of the crossing, so loss of temperature and pain sensation on the contralateral side, and obviously loss of proprioception and vibration senses on the same side. So this is presentation which is similar in an intradural extramedullary lesion to start with, which is an AIIMS. Whereas when you have an intramedullary lesion, see, both an intramedullary lesion and intradural extramedullary lesion, both of these come under the category of broad intradural lesion. So an intradural lesion, you need to understand, can be an AIIMS or it can be an intramedullary lesion, depending on, or it can involve both the compartments also if it's an extensive tumor. So where an intramedullary lesion is there, which is growing around the central canal, it will involve what is called as the anterior horn cells. The anterior horn cells bilaterally, and it might lead to flaccid paralysis, and it will involve the bilateral spinothalamic tract which are crossing to the either side. So this will lead to the typical loss of temperature and pain sensation, and might lead to dissociative sensory loss. So this is very, very important anatomical consideration, which is relevant for the clinical assessment. So because a diagnosis of a spinal tumor, which is an intradural or extradural or intramedullary, eventually will need a clinical assessment, a clinical diagnosis, and it will need a radiological diagnosis. So when you are presenting your case summaries as long and short cases in your exams, you will be expected to give what is the clinical diagnosis. And people generally ask you, what is the horizontal level of this? When people ask you what is the horizontal level of this lesion, they basically want to know whether this lesion is extradural, or whether this lesion is intradural and extramedullary, or whether this lesion is intradural and intramedullary. So these cross sections and this anatomy of the spinal cord and the relative relation of the various tracts is very, very important for residency. As far as the epidemiology is concerned, so in intradural tumors, for intramedullary tumors are much common in pediatric age group, as you can see here, as compared to adults, where intradural extramedullary tumor, which are the AIIMS, are the most common. So this is very, very important. So the relative proportion of patients who have intramedullary tumors is much more in pediatric population as compared to the adult population. As far as your intradural extramedullary tumors are concerned, the most two common tumors are the meningiomas and the schwannomas, followed by neurofibromas, which can occur as intradural extramedullary lesions. There is a few group of ependymomas which might also present as an intradural extramedullary lesions, so followed by metastasis. So most commonly these two tumors, either a meningioma or a schwannoma followed by neurofibroma, are the most common diagnosis for an intradural extramedullary tumor. Whereas for an intradural but intramedullary tumor, the most common diagnosis remains to be astrocytoma in pediatric age group. This thing you need to remember: for pediatric age group, the most common intramedullary tumor is an astrocytoma. But if you take an adult, the most common tumor in adult is an ependymoma. So this is the difference you need to remember, that in pediatric age group, the most common intramedullary tumor is astrocytoma, whereas in adults it is epidemioma, and followed by hemangioblastoma and other lesions. So this table I have included for residents especially, where they need to remember that on clinical history and examination, what are the differences of a lesion which means extramedullary versus an intramedullary. So extramedullary, as I have already shown you, the onset is generally asymmetrical because the lesion is generally rising from the one side and starts the compression of the spinal cord from outside. So generally the onset is asymmetrical. Only one side is getting involved first. Whereas an intramedullary lesion, generally bilateral involvement is there. That is why the involvement is symmetrical. Then the pain, because generally intradural extramedullary lesions like a schwannoma or a meningioma might have close association with the nerve roots and are arising outside the spinal cord substance. They generally present with what is radicular pain, if especially, or might present with local pain if they have an extradural extension. Whereas intramedullary lesions generally cause what is a dull aching funicular type of pain. The UML signs are much more earlier seen in an intradural extramedullary lesion as compared to an intramedullary lesion, where the UML signs come late. As I already told, the sensory involvement, okay, is generally ascending type, okay, in intra, because the sacral tracts are located much more on the outside, whereas in intramedullary lesion, it is generally descending type. Disorderly sensory loss is a characteristic feature which I have already told you of intramedullary lesions, where they generally involve the areas around the central canal and involve the bilateral spinothalamic tract. And similarly, because the region, the fibers which control the autonomic fibers, they run in close proximity to anterior horn cells close to central canal. That is why these also get affected early in an intramedullary lesion. So all these points are very, very important for your clinical history taking an examination while you are giving your long and short cases for your final exam. So I think so this table is very relevant for residents. Once you have made a clinical diagnosis, now we need to move on to a radiological diagnosis. So now we'll discuss what are the radio anatomical considerations for intradural extramedullary tumors. Hello, sir, am I audible clearly? Is there
Yeah.
Yes,
There was
you're
some
audible. Yes,
yeah,
some
you're-
disturbance from other mute. You
Okay.
continue. Your voice is clear. No problem.
Okay. So now we'll go to the radio anatomical considerations for pediatric intradural extramedullary tumors. Now we had already discussed the most common tumor, which is generally a meningioma. So it has a strong female predilection. Generally, much most common location is the thoracic spine as compared to a cervical spine. If there is a history of ionizing radiation or previous radiotherapy, it is generally a risk factor. Now, meningiomas in spine can be associated with NF2. Okay. They are generally T1 iso to hypointense and slightly T2 hyperintense. So this point that they are slightly T2 hyperintense and in some cases might be even hypointense is very important distinguishing factor from schwannoma. Schwannomas are generally much more bright on T2, much more inhomogeneous, much more cystic changes, which we'll discuss later. Meningiomas are generally associated with enhancement, brilliant enhancement with a dural tail, and there is evidence of calcification in some cases. So another very characteristic finding, which is characteristic of meningioma, spinal meningiomas, is what is called a Jingo biloba sign. What is Jingo biloba sign? It is nothing but a fan-shaped deformity of the spinal cord, which is rising from the lateral part. As you can see here, it is rising laterally and ventrolaterally, and it is pushing the cord. This is the normal cord. So it is rising here and it's pushing. It has a streak inside it. This streak is nothing but the stress dentate ligament. So actually, the deformity is created by the tethering of the tumor to the dura and the stress dentate ligament, and it gives you that fan-shaped appearance of the cord. This fan-shaped appearance of the cord resembles the leaf of Ginkgo biloba. So it has been described in literature as a leaf of Ginkgo tree sign, a very characteristic feature which shows the stretching of the dentate ligament and is seen in spinal meningiomas arising laterally or ventrolaterally. Another thing, you might have calcifications and you might have very, very firm meningiomas which are T2 hypointense, very hard, very fibrous, and might have calcification. As you can see, there is evidence on CT also for calcification. So how do you distinguish a meningioma from a schwannoma? So meningiomas are arising from the dural surface, maybe dorsal, maybe ventral, maybe ventrolateral, maybe circumferential also. Whereas schwannomas arising from the dorsal lumbar spinal nerve roots. Both of them can have association with NF2. The important thing which distinguishes a schwannoma from a meningioma is that schwannomas, because they are arising from the nerve roots, they have foraminal extension. This is very, very important. And they are much more brighter on T2 as compared to a meningioma. Much more brighter. But the enhancement they have, that is heterogeneous, and because of this heterogeneous, because they have areas of cystic degeneration. This is very, very characteristic of a schwannoma. So these features helps to distinguish a schwannoma from a meningioma in a spinal tumor. So how do you distinguish it from a neurofibroma? Most neurofibromas are generally asymptomatic and they are associated with NF1. See, this you need to remember. Neurofibromas are associated with NF1. Meningioma and schwannomas are associated with NF2. Okay. And generally most neurofibromas are diagnosed because of some other systemic finding, and they are generally pain-free. Unless, and they are generally multiple. They are not restricted to one part. They may be multiple. Like when you see multiple small neurofibromas, they generally become symptomatic when either they are kissing from bilateral sides, they are paraspinal extension, or they are compressing from multiple areas. Important thing which you need to remember is a neurofibroma encases a nerve, whereas schwannoma generally displaces a nerve. Schwannomas generally tend to rise eccentrically and they generally tend to displace the nerve roots rather than encasing it completely, whereas neurofibroma tend to encase the nerve roots. And they might have plexiform bag of worm-like appearance if they are associated with multiple lesions spreading over multiple areas. So sometimes you might have a malignant peripheral nerve tumor which occurs in NF1, which might have a prior radiotherapy. Generally, if they occur in children, it has very poor prognosis and they tend to go into the paraspinal spaces. Like you can see here, this tumor has exited the spine and is going to the paraspinal spaces. So generally a very rare tumor, but yes, they might exist, and in children they generally have a very poor prognosis with extensive paraspinal extensions. Now myxopapillary epidemioma. This is one of very common tumors which is seen in pediatric age group. It is the most common primary neoplasm which is of conus medullaris or cauda equina region. Patients generally present with severe low back pain, might present with foot drop, might present with urinary incontinence, might present with a complete cauda equina like presentation. So you can see here, typically at the end of conus, you have a T2 hyperintense and intense contrast enhancing lesion, and if it is involving the bowel bladder and involving the conus, then it generally has a poor prognosis. So very characteristic appearance of a myxopapillary epidemioma, which is seen in pediatric age group. Rarely, you might have multiple small studied intradural extramedullary lesions having nodular enhancement, presenting with widespread symptoms of motor weakness, bowel bladder involvement, ataxia, and even might have cranial symptoms. In such cases, you might suspect a malignancy, which is having a leptomeningeal metastasis spreading from other parts of the body, or it might be a dissemination of a lesion in the brain. So in such cases, you need to go at a FDG PET for the patient for diagnosis, and you need to get a screening MRI brain as well. And such lesions are not singular, there are multiple small nodular enhancements. So with this, we come to the end of intradural but extramedullary tumors. Now we'll come to intradural but intramedullary tumors, which are arising from the substance of the cord. So as I have already told you, the most common intramedullary tumor in children is an astrocytoma, and in an adult, it's the epidemioma. Astrocytoma generally commonly occur in the thoracic cord, followed by the cervical cord. And important thing you need to remember is that the astrocytomas, they arise from the glial cells from the cord parenchyma. So they generally are located eccentrically within the spinal cord. So this is an important difference which might notice in an axial image, because astrocytomas are generally eccentrically placed as an intramedullary lesion, whereas epidemiomas are centrally placed, because epidemiomas generally arise from or around the central canal, whereas intramedullary lesions like astrocytomas, they arise slightly eccentrically from the substance of the spinal cord, slightly away. So they might displace the central cord eccentrically. Spinal epidemiomas, most common tumors in adults, we have already discussed. T2 hyperintense, and what you need to remember is a typical cord as hemosiderin cap sign. So this hemosiderin cap sign is generally seen at the end of the lesion, wherein a hypointense hemosiderin rim is seen on T2 weighted images, which is stated of mild hemorrhage. So this cap sign, which is on either side of this rim, is very characteristic of an epidemioma. Then you come to hemangioblastoma, which is the third most common tumor, most commonly located in thoracic cord. Again, it might be associated with multiple lesions, especially if it is associated with multiple lesions like similar small. Then you suspect von Hippel-Lindau syndrome. Generally, it is a densely enhancing nodule which is associated with dilated arteries and prominent draining veins. And you might see multiple small flow voids. You can see in this image multiple small dilated vessels all around. So this is very characteristic of hemangioblastoma. And you see a Doppler image and you see a DSA image where that nodule gives a prominent blush. And here you can see multiple flow in Doppler also. So this is very characteristic of hemangioblastoma. And hemangioblastomas generally have a secretory function, so they might be associated with a syringomyelia also, generally upstream, or maybe a hollow cord syrinx also. So this, if you see a intramedullary lesion with a nodule with multiple dilated vessels with a syrinx, your suspicion goes towards the angioblastoma. Now another common lesion which is seen in pediatric age group, not exactly a tumor, might present like a tumor, but it's a dermoid cyst. Now dermoid cyst might be intramedullary, might be extramedullary also. They may not be in the substance of the cord as a whole. They might have some extensions which is outside the cord in the caudal region, and might be intramedullary also. So such patients present with what is called as conus medullary symptom. It might present pain, sensory disturbances, gallbladder involvement, because conus might be involved. The characteristic feature is these lesions are hyperintense on T1 because of presence of fatty secretions of the sebaceous glands, and might show diffusion restriction also. The worst problem with these lesions is their risk of recurrence. Such patients get operated multiple times. So very careful. You have to remove, and the risk of deficit, remove the capsule as much as possible, because the risk of recurrence is very high, and you have to counsel the patient accordingly. But it is a very common tumor lesion which is commonly seen in the lumbosacral regions, pediatric age group. So with this, I'll come to the end of the most common lesions. So to summarize, I just want to say that the most important thing for residents is to understand the basic anatomy of the spinal cord. You need to know the most common tumors, agreed, but till you understand how to make a clinical diagnosis in a patient with a spinal tumor, whether an adult or a pediatric, it is very important that you should know the location of the various tracts in spinal cord, what is the relative position of sacral to cervical region fibers, and what is the possible horizontal level in a particular patient, and what is the likely diagnosis based on imaging. So this is what is a take-home message for all the residents. I think so that image which I had already shown of the spinal cord tracts, the differences between intramedullary and extramedullary lesions, and the most common intramedullary and most common AIIMS lesions, their characteristic imaging findings. I think so. If these as residents you can learn and revise, I think so you are good to go for your final exam. Okay, thank you, sir. I think so I'm done.
Thank you, Dr. Ravi, for a very lucid description of the epidemiology and the radiology of common spinal tumors. So, are there any questions from the audience? There is nothing in the chat box, but you succinctly summarized what is important, the cross-sectional anatomy of the cord, and how clinically it affects based on the location of the lesion. So we will take any further questions at the end of the second lecture so that it's in continuity. I now invite Dr. Satyashiva Munjal to present his talk on the spinal intradural extramedullary tumors. He will be now discussing on the surgical techniques and what you should be taking care of when managing the IDEM. So Dr. Ravi has already told you how to arrive at a diagnosis and some radiological findings which clinches one tumor over the other. So Dr. Satyashiva will take you further in this journey of intradural extramedullary tumor surgical technique. Dr. Satya, please.
Thank you, Dr. Sachin. Thank you, Dr. Suhas and the Pediatric Association. I will now share my screen. Are my slides visible?
Yes, yes. Make it full screen. Yeah, yeah. Good.
Yes, yes.
Thank you
So
so
I
much.
will. Thank you, thank you. So I will be. Thank you, Dr. Ravi, for giving a sound platform for my talk. In contrast to Dr. Ravi's talk, my talk will be absolutely clinical and will help you how you work in the OPD and in the OT. This is not much of theoretical and will not probably be very useful for your exams in contrast to what Ravi told you, but will be more useful in the OPD when you see these patients and when you go to the theater. So how spine tumor surgery took a lot of time to evolve, and it's more very complex because it is highly morbid. So the first successful resection of an intradural extramedullary tumor happened in 1887 by Victor Horsley, and initially for intermediate tumors, in fact, Ellsberg, advocated a two-stage approach. In first, he would expose, and in the second stage, because of morbidity and all, he would then remove the tumor. With advent of cautery in the 1940, initially a monopolar cautery by Bovey and by bipolar by Greenwood, things started to move ahead. Then the advent of operative microscope in 57, microscope surgery became the main approach. With advent of radiology, with CT and MR, it became further, evolved. The diagnosis, the localization of the tumor became further refined, and it was easy to, localize the tumor and operate on a specific part, as contrast to earlier years where, a clinical judgment was used to localize the tumor and operate, so thereby increasing the morbidity. Advent of QSI in 1978, using of ultrasound, and then advent of the neuromonitoring in the 1990s and further development, has tremendously helped to decrease the morbidity on operating on these tumors. First of all, we should know when to operate these intradural extramedullary tumors. These are usually slow-growing tumors. Most of them are usually benign. So operate on them, broadly speaking, when they are symptomatic. If they are asymptomatic, one needs to be very careful or cautious whether the patient needs surgery. Also, you can see, this is one of the papers that I'm showing you, that these tumors, the spine tumors, usually are late to present, and the deeper the tumor, the later that presents. So we must keep this in mind, that already significant destruction of the tracts must have happened, or displacement of the tracts must have happened by the time the patient has come to us. If the patient is asymptomatic and the lesion has been detected incidentally, we must be careful in further evaluating the patient before embarking on the lesion that we have seen. Are the tumors multiple? Are there elsewhere tumors in the body? Are there any cutaneous features pointing to a phakomatosis? If any of these features is present, we must work up for genetic syndromes. If it's an isolated incidental tumor, is it extramedullary or intermedullary? If it is extramedullary, we need to assess on the radiographic feature and try to infer pathology and natural history of the tumor. If it's causing cord compression, seems to be a high grade, causing spine deformity and hydrocephalus, we need to go for tumor resection. Or if there are no such features and the patient is asymptomatic and has no syringomyelia or uh, any other presentation with cord compression, we can actually follow this patient on a 3-monthly or a 6-monthly basis. Overall survival in these tumors is better than the intramedullary or the extradural tumors on long term. Goes to show that careful case selection and careful execution, meticulous execution of surgery can yield very good results. But one must be careful by seeing what one is getting into. If the lesion is more than 3 levels or seems to be high grade, these are the two most important factors deciding the prognosis in any pediatric spine tumor. More so in intramedullary, but also this applies to intradural extramedullary as well. The availability of 3D printed models can be a useful adjunct when you are planning for surgery, and it has been shown that it provides a more comprehensive understanding of complicated pathology. In the figure shown, you can have it, you can see there's an extra foraminal extension of the tumor and how the vessels are encased over it. You can have another model showing the destruction of the bony elements, though the vessels are not shown in this model. Advent of neuromonitoring has radically changed spine surgery to our approach to spine surgery. Motor evoked potentials have a higher predictive value. So in some cases, it may limit the extent of tumor resection, but definitely they have a strong predictive value in predicting long-term neurological deficits or permanent neurological deficits. So whenever possible, we must use neuromonitoring, especially motor evoked potentials. Even if you, sorry, I'm sorry. even if you Even if the deficits, immediate deficits, may be similar with or without neuromonitoring, studies have shown that functional outcome at 3 months post-operatively are better in patients in whom the monitoring was used. By definition, SSAP changes that are considered at warning levels include a 50% drop in amplitude or a 10% latency prolongation. For MEPs, a decrement in amplitude of 50% has been shown to correlate with permanent neurological deficit. Preoperatively, in the theater, patient should have an arterial line placed for continuous mean arterial pressure recordings. For the adults, we have recommended a mean arterial pressure of 80 to 90. But in pediatric patient, the goal is to maintain the patient's baseline mean arterial pressure or slightly higher to avoid hypoperfusion of the spinal cord. Paralytics are avoided and total intravenous answers are given for if you are using neuromonitoring. Dexamethasone steroid is given with a pre-operative loading dose ranging from 4 to 10 milligram depending on the weight of the patient and is continued 6 hourly during the periodic period. Neuromonitoring can be as extensive as possible, depending on the system you have. Motor evoked potential, SSCPs, D waves, even dorsal subcortical mapping if you're doing intramedullary surgery. And this makes a safer maximal resection of tumors. So patients are positioned prone on a 3-pin, or you can use a head frame or a horseshoe. Lateral X-ray films are obtained for localization of the level by counting down either from C2 or up from the lumbosacral junction. For thoracic lesions, you can even use a localizing X-ray pre-op by using a marker X-ray may be done. And muscle exposure, after the muscle exposure, a localizing X-ray is obtained prior to performing a laminectomy, because sometimes the skin level may not correlate with the bone level when you go inside, especially if the child is a little bulky. And whether you want to do a laminectomy or laminoplasty, this plan you must do pre-operatively. Always preferable to do laminoplasty, because studies have shown laminoplasty, though does not prevent long-term deformity, but definitely delays the onset of sagittal imbalance or kyphosis in these patients. So after a midline exposure, this is a standard midline exposure, one must make all attempt to save the supraspinous and the interspinous ligaments. The muscles are dissected subperistally over the lamina and divide them caudally and inferiorly to lift it in one go, the spinous process. You can use a bone cusa or the foot plate cutter to lift it like a fish bowl, or a fish tail, and try to save the supraspinous and interspinous ligament, especially if you are doing multiple levels, more so if you're doing more than 2 or 3 levels. When exposing, take care not to violate the facet joints. One must not go very lateral, stay up to the middle part of the facet joint. The cutter, if you are using, or a bone cusa if you are using, try to angulate it medially so as to avoid violating the facet joint. Because the more the levels you violate, the likelihood of post-op deformity increases over follow. Once the laminectomy is complete, usually if your localization correct, you will see a bulge of the tumor. If the bulge is not very apparent, you may use the ultrasound to localize and confirm the presence of tumor. And you must confirm the bony removal before you open the dura. Meticulous hemostasis and irrigation of the epidural space should be performed to prevent bone dust and blood going into the intradural space. Therefore, use of ultrasound prevents the error of judgment in opening the dura before the bony work is complete. Durotomy, a standard midline durotomy is used. We have shown this as an example here. Stay sutures are used using a very thin 30 or 40 skill sutures and applied to a mosquito forceps on both the sides to lay the cord open. And once the tumor is exposed, one tries to identify the spinal cord tumor interface. Usually it is unilateral and pushing the cord to the other side. But in large tumors, sometimes the cord may be draped over the tumor, and one we need to be careful about it. The tumors are, because you want to avoid cord retraction and cord handling. So the best method to do that is to do internal debulking and then going out to periphery. When the tumor is small and has reduced in size, you can even deliver the tumor out of the cavity as shown in the image. You can also use an ultrasonic aspirator to help you with internal debulking. Tumor resection is continued until there is no visible tumor as available as guided by the microsurgical evaluation, or you may even use ultrasound if the tumor is little ventral and you do not want to retract the cord. After removal of tumor, meticulous hemostasis is done and dura is closed in a running watertight fashion. If for some reason only a biopsy was performed, an expansile duroplasty should be considered. Wound closure follows the same rules as in any spine surgery, a meticulous lavage of the muscle layers and the fascia. You may also consider use of vancomycin or povidone iodine, as it has been shown to reduce infection rates after closure. In the post-op period, one must avoid hypoperfusion and maintain the mean arterial pressure at the patient's baseline for the first 48 hours. You can taper the steroid gradually to treat the perioperative cord edema. Do not allow aggressive or activity. Mobilize the patient, but do not allow heavy activity for the initial 48 hours to minimize the risk of CSF leak and subdural collection. And if your center has a protocol of getting an immediate post-op MRI, get it within 72 hours of surgery. The big question here is why not to do a laminectomy, or why to do a laminoplasty, and how much bone removal should be done. It is a very important concern and a consideration in spine tumor surgery, because this example, this case we have operated last week only was operated elsewhere, and only a two-level, laminectomy was done in this case, and he has developed, this boy is a 20-year-old boy, and he has developed kyphosis within 2 years. So you see how morbid can laminectomy be, even though this is not a very long-term follow-up. Otherwise, comparing laminectomy and laminectomy with fusion, there is no difference in postoperative pain, neurological deficit, functional independence, CSF leak, or wound infection. But laminectomy has greater odds of causing sagittal instability as compared to laminectomy with fusion. So patients who have a large tumor must be offered fusion, must be considered for fusion. Now, there are certain concerns, and why we are discussing this issue is that, as compared to adults, a large proportion of children will develop deformity, and attempts such as laminoplasty or a skip laminectomy and preservation of the posterior osteoligamentous gland are performed with the intent of reducing the risk of post-laminectomy deformity. So, patient less than 3 years, already having a deformity, decompression spanning the entire axial cervical spine or the junctional area such as the cervical thoracic region, removing of 3 or 4 lamina, aggressive fascectomy has happened to remove the tumor, and presence of an extradural lesion which is causing destruction of the pedicle, and severe myelopathic symptoms are risk factor for developing post-surgical spinal deformity. But one should not be paranoid about fusion when he is going for tumor surgery. Decompression of the neural elements and resection of the tumor takes precedence and priority over fixation and correction of the deformity. Even when we are correcting the deformity, it is recommended to avoid distractive maneuvers and do compressive maneuvers only to avoid over lengthening of the canal and stretching of the spinal cord, which is already compromised by tumor compression. As a surgeon, one must balance his approach to preserve the growth potential of a pediatric patient and again, vis-a-vis his need for stabilization in the spine. Because if you fuse very early, he will develop his growth will be hampered, and he may develop a secondary deformity as a result of the fusion. Not only surgical insult, but even radiotherapy, if the tumor is high grade and he receives radiotherapy, this also causes a late onset spinal deformity in children. And we must keep this in mind and continue to follow these children even after their adjuvant therapy. Because even radiation therapy can affect the growing spine and lead to asymmetric vertebral growth. Various correction of these deformities is not unfortunately a part of this discussion, but various algorithms are available to follow depending on the deformity that develops in these cases, and usually recommended for adults. One usually does an anterior release also if required after initially one should evaluate using a dynamic radiology like a dynamic cervical spine x-ray, whether it is a flexible or a rigid deformity. A rigid deformity will leave release of the facet joint as well as sometimes anterior release to achieve a appropriate correction. Thank you. Uh, these children, when we operate on these cases, we must remember that sometimes this may not be a single visit to the hospital for them. And we must be very meticulous in our wound closures and dural closures so as to minimize their morbidity. As this study shows, within 90 days, a large percentage of these patients come to the hospital for some or the other reason. Either they're coming for their adjuvant therapy, Either they're coming because of their spinal deformity, either they have developed some surgical site infection or systemic infection or pneumonia, or other because it might be a genetic syndrome. So the cranial is also involved. So they're getting a VP shunt or are having seizures or some other problem. So all the more reason to be very meticulous with these surgeries. Thank you.
Thank you, Dr. Satya. He told us about the important surgical tips and the use of neuromonitoring, as well as lot many things, the post-operative complication, the advantages of laminoplasty over a laminectomy. So all these are pretty important when you manage these cases. So are there any questions? There is one question by the regarding neuromonitoring, and Dr. Suhas has also replied. I also replied. Neuromonitoring is is a very useful adjunct in spinal cord tumors. So if you are operating in the intramedullary space, it like an astrocytoma or ependymoma, it gives you a added safety, and obviously medico legally also you will be safe that you have used the best available technology to monitor function. So there are now a lot of, other than the motor evoke potential and the SSCP, there are now D wave monitoring, which is also a very good adjunct and gives a long term prediction of the safety of or the preservation of neurological function. So whenever available, you should definitely use it, especially for intramedullary tumors. Intradural, extramedullary, they are outside the cord. So if you are careful and with good microsurgical technique, IDM, you may not need neuromonitoring. Always, it's not a must. But that answers the neuromonitoring question. The any other question from the audience you can all put right now as well. So to summarize what I will like Dr. Ravi to summarize his talk and the learning points once again for you. For 2 minutes, he will tell what he has covered in 20 minutes, followed by Dr. Satya, and then we will conclude. Okay, so Dr. Ravi, you can
Yes.
just give them the take home message once again so that it's useful for them.
So the take-home message for all the residents is that first of all, you have to learn how to make a clinical diagnosis of a spinal tumor and how do you make a radiological diagnosis of a spinal tumor. When you make a clinical diagnosis of a spinal tumor, you need to define what is the horizontal level for that spinal tumor and what is the vertical level for that spinal tumor. When I say horizontal level, it means whether that tumor is located in extradural space or it is an intradural extramedullary or an intramedullary. So you need to know what are the clinical features on presentation which will distinguish these three. And then for that, you need to know what is the basic anatomy of the tracts in the spinal cord and what are the differences of presentation of an intramedullary lesion versus an extramedullary lesion. For radiological diagnosis, you need to know what are the common AIIMS like meningioma, schwannoma, neurofibroma, and how you can distinguish them radiologically, and what are the common intermediate tumors like astrocytoma, epidemiology, hemangioblastoma, and how you can distinguish them radiologically. So, and sometimes dermoid cysts. So this is actually a clinical diagnosis and a radiological diagnosis for spinal tumor. This is what I talk about. So we can all the important clinical things, you should practice them while you are examining your patients in your OPD or in your ward. That is must for your long case and short case preparation finally. That's the message from me. Thank you.
Yeah. Dr. Satya can also summarize regarding the IDM.
Yeah. IDMs can be multiple. So I would suggest that one must confirm correlate the symptoms clinically with the radiology before embarking on surgery or advising surgery. That is one. and meticulous planning of the surgery. How much bone will I remove? How will I expose the and try to minimize my exposure. If I can do with the hemilaminotomy, if I can do skips laminotomies, if I can use a bone CUSA, I want to minimize the morbidity of the exposure. Use of neuromonitoring is not compulsory, but desirable, and use of adjuncts such as CUSA to minimize cord retraction and handling is advisable. That's it. And follow-up, regular follow-up to see whether these patients are developing some kyphosis or some deformity.
Yeah, so follow-up is also pretty important, and indeed, they develop a growing spine has a tendency to go into kyphosis if it's a long segment laminectomy. So always
Yes.
try to do preferably a laminoplasty than a long segment laminectomy.
Yeah. Yeah.
So that will help
Yes.
prevention of
Yes.
kyphosis.
Yes.
So
Yes.
Sachin,
overall,
Sachin,
yeah.
Sachin, I have two more messages to add along with Ravi's and Satya's. One is when it comes to clinical scenarios, the presentation in children may not be textbook like. So you have to. I mean, when you have a smallest child, you cannot pick up the levels, etc., etc. So watching a child before you touch the child from far off, talking to the mother in detail about the movements and the child's activities, etc., is much more probably more informative when it comes to the youngest ones. That's one when it comes to the clinical part, and surgical part. Like along with what Satya said, one more perspective which I would like to add is like any pediatric scenario, preparing for a safe surgery from temperature onwards to the anesthesia to anticipating blood loss and all the avoiding morbidity is equally important apart from the specific scenario of the spinal tumors in specific. So there are the two separate things which I thought I'll add to being a pediatric class. Thank
Yeah,
you.
yeah,
You can
yeah.
proceed.
Thank you so much, Dr. Suhas. So what
Thank
Dr.
you.
Suhas told is pretty important in any pediatric case to have the proper temperature of the OT. At times, the patient develops hypothermia because they are long surgeries. So all these factors have to be taken care of while you are operating on these small kids. And overall, so take home message is again, so see the radiology well, diagnose if it's an extradural, intradural, extramedullary, or an intramedullary tumor based on the tips which Dr. Ravi just elucidated, the expansion of the cord, the displacement of the cord, etc., the associated syrinx, the arachnoid cap, especially in case of an ependymoma and all those things. So that's important. When you are planning surgery, the prerequisite of having a temperature, blood loss expected, anticipated, and proper arrangements are important. And try to do a laminoplasty compared to a laminectomy. Be very careful with. Don't handle the cord at all. Handle the tumor and do internal debulking with CUSA so that there is minimum traction on the cord. And so all these factors are important and play a very they have really good outcomes if done well. The extramedullary tumors are actually very gratifying surgery. The patient who been have a significant deficit usually improves if you remove them well and without inflicting, because they are outside the cord. Intramedullary are a different scenario which we'll discuss in subsequent virtual classroom. uh, so this is from my end. I hand over to Dr. Suhas to just have a concluding remark.
Thank you, Dr. Sachin. At the outset, I thank Dr. Ravi and Dr. Satya for an excellent focused session on the pediatric IDM and the basics. It was an extremely useful one, and I'm sure the residents would have benefited. To conclude, I would say that the next class is going to be on July 28th, the last Sunday of the next month. That the topic would be on intramedullary spinal cord tumors, which would complete the spinal oncology part. And for all the residents who would have missed or who are not concentrated, the talk will be available on the YouTube channel of the IndusPN. Thank you all from on behalf of IndusPN, teachers, the teachers who have participated, Dr. Sachin, and the residents all. Thank you.
Thank you.
Have a nice weekend.
Thank you, sir.
Thank you so much. Yeah.
Thank you, sir.
Yeah.
Thank you so much, sir. Thank you so much, everyone.
Thank you.
Goodbye.
Thank you.
Yeah.
Thank you.